Yeah, my topic is aortic valve operations at Hamad Medical Corporation. Now we move to the heart hospital, of course. But we still remain part of Hamad Medical Corporation. As probably some of you know that cardiac surgery started early 1980s, 1983. In fact, the first operation was performed. I was not here at that time, but was performed by a colleague, an old colleague of mine, who was here and left. It was, in fact, the first surgery was an aortic valve replacement, and it was performed in June 27, 1983. It was in a 30-year-old Qatari gentleman. I'm not sure if he survived, but at least that was the operation. And since that time, cardiac surgery expanded, although the population of Qatar, in fact, was small, and the number of cases was small, but developed over the years. Since that time, we did 6,630 operations. Out of these, 493 were aortic valve replacement, which is 7.4%. This is just to show, at least over the last 4 years, the growth of number of cases in cardiac surgery. It's not so significant, but there is a trend towards increasing number of cases. At least in the coronary artery bypass surgery, the valve probably remained the same, and then capital valve remained the same. Thoracic probably is the same, but we're expecting that with in the heart hospital, we already in fact have experienced a larger volume of cases because of availability of space, more let's say the population has gone up from exponentially. In fact, over the last few years, the population is 2.2. In fact, 2 million now. So we're expecting that the number of cases will go up. In fact, the total number, as I mentioned, was 6,000. But I'm just going to show some statistics from 1995 to March 2012. The problem here is, I apologize for this, because we don't have, unfortunately, we don't have accurate, complete data with regard to cardiac surgeries, but what you're going to hear is what we have. To have more data, in fact, you need to go back and search into the files, and that's cumbersome. That's why, in fact, recently we acquired a new database system. Hopefully that will solve the problem. At least we did 4,909 cases of total cardiac operations since 1995, and 5% of those were aortic valve operations. But in total, in fact, at least 15% were valve surgeries. 5 to 7% of those were aortic valve operations. Female, in fact, represent 24% of the cases, and it's predominantly male population. And this is the age distribution of aortic valve surgery. Most of the cases fall in this age range, which is 21 to 70-year-old. Of course, with different underlying pathologies. The younger tend to be rheumatic, the older they tend to be degenerative, and probably middle age tend to be either bicuspid aortic valve or aortic regurg as a consequence of probably rheumatic heart disease or aortic annular aortic ectasia and so on. This is distribution according to nationalities. Group 1 represent, let's say, the Indian subcontinent, and they constitute either India, Bangladesh, Pakistan, Sri Lanka, and so on. While Philippines are not, do not fall under the Indian subcontinent, but we just stack them together. And in fact, most of these are let's say, the Arabs, in fact, represent, have more, I mean, our population is mostly Arab or Middle East population. The Indians also represent a large percentage. The Qataris, in fact, these are the Qataris, which is only 29 cases. Probably that also represents the total population in the country. Over 2 million population, Qataris represent only 20 or 25% of the population. And this is the number of cases done over the years. As you probably can see there, there's an increasing number of cases. I think this probably is an accurate 2011, 2012. We're still in 2012, of course. But I think there's an increasing number of cases over the last few years. And these are the procedures which were done. Mostly isolated AVR with cabbage, AVR and MVR, mostly for rheumatic heart disease, and this is AVR, MVR, and cabbage. In fact, we've done very few RUS operations. These were mainly in congenital. These are not shown here, of course, but these are done in congenital cases. Well, we've done few repairs, but these are only very few. Having said this, because of the young age group, in fact, we have a good post-operative follow-up, because most of these patients would receive a mechanical valve, so they need a close follow-up. And we have a warfarin clinic, which in fact follows up those patients on regular basis. Although I don't have a data of let's say long-term follow-up of the mechanical valve or urinary tissue valves, of how many of those would come back with thrombosed valves or and so on. But at least, in fact, we have let's say a busy warfarin clinic, which sees at least 40 cases per day. These are not only patients, post-operative patients, but also a variety of cases. But we have close follow-up of those cases. Yes, I mean, most of these receive mechanical valves, but I think I haven't seen, at least for the last few years, any of those presenting with thrombosed valves. In fact, we've seen few cases who came, who came newly to the country and presented with stuck valve or thrombosed valves. That's all the data I have. I apologize for let's say incomplete data. I'm sure that there are more questions than the answers which I'm expected to do.
Abdulwahid, thank you. I was anticipating you would show the demographics you did about the number of patients who were Qatari versus expatriates. And I'm assuming also that the patients you operate upon who come from India, Bangladesh, Yemen, and so forth have rheumatic disease, but are they also showing up with more advanced disease, greater comorbidities, higher operative risk than the Qataris, who maybe followed a little more carefully preoperatively?
Some of them, yeah, they do, in fact, because these are advanced. Maybe we'll hear from Dr. Ahmed Mutarraf from Yemen. Some of them come with advanced rheumatic heart disease, severe pulmonary hypertension, and so on. But still, I mean, the operative mortality is relatively low and comparable to international figures. They're not denied of surgery. I mean, we go ahead and operate on those.
Questions for Dr. Abdulwahid? What is your choice of valve then for, you have such a spread of population, including young people, and so what are you recommending for 35 to 50-year-old individuals, bioprosthesis or a mechanical valve?
Well, we go according to the guidelines. I'm sure if you ask Professor Yaqub, he'll answer differently. He would say Ross procedure. But here, in fact, we replace it by mechanical valve, unless it's contraindicated. As I said, because we have a close follow-up, and at least the ones who stay in the country, in fact, get good care post-operatively. So most of them would receive a mechanical valve.
As your TAVI program begins to roll out, you will have interesting discussions with younger people, as I'm sure Carlo has already intimated about perhaps being a potential candidate for a valve and valve procedure at a later age. And so our patients are asking that question now. It's a very difficult one to answer without lots of data.
But how many valve and valve we could...
No, exactly. how many times can you do that?
No, not for young patients.
I agree, yeah. I agree. Sir Mandi.
Thank you very much for such an interesting set of data. My question relates to the valve substitute. You see from the data you showed, you have about 25 to 30 patients per year. Now, there is some evidence, but not totally substantiated, that the type of prosthesis does influence both the survival as well as the quality of life. And therefore, like what Professor Bono said, there are very few randomized trials, and that then it behoves us to supply the evidence, class 1, and therefore we need to do randomized trials. And we're thinking about the so-called Ramses trial, randomizing patients between the age of 30 and 65 to one of 3 options, a prosthetic valve, an unstented valve, or a Ross. And this will be a multi-center randomized trial. Do you think we can start in Doha, participate in this envisaged trial in the future?
Yeah, I don't see why not. I guess we could do that. We could participate, although the number is small, of course. I mean, it's, but we could be part in that study.
Yeah, so long as. Do you think the patients will accept randomization? And if we talk to them nicely and explain that really there is an equipoise and we don't know the answer?
Yeah, it all depends on how you put it to the patients, I guess, in the end. Yeah, you may have difficulty here, in fact, to convince patients to undergo, let's say, trial, because they consider this as an experiment. So they're kind of wary about this. Maybe difficult to convince them, but we could try.
Thank you.
How frequent you perform aortic and mitral valve repair in case of rheumatic heart disease, especially in young ladies?
Even aortic repair and mitral repair? Well, but we don't have experience in aortic valve repair. We have experience in mitral valve repair, yes, but these are very, very small number. If this subvalvular apparatus is okay, let's say, then yeah, one would let's say do repair or attempt to do a repair. But if the subvalvular apparatus is badly affected, then you just replace it. And these are, because most of these cases are non-citizens, non-Qataris. So they come with, and these are sporadic cases. They're not here, they're not followed up, and so on. So these are a variety of cases. They present differently, in fact. Our experience with mitral valve repair, I would say, let's say 30% of them, rheumatic mitral stenosis, 30% of them are repairable, not more than this.
I think we have time for one question, and then we should take our break. We have a mic in the back, or?
My question is actually to Dr. Abdulwahid and Professor Di Mario. Do you think the initial data from valve-in-valve implantation is enough to justify offering younger patients tissue valves, hoping that by the time they require redo, should they require any redo, TAVI will be a good option?
It's a great question. That's, I guess, what I was trying to begin to get into, because it's quite controversial. But we often will put in a bioprosthetic valve in a 50-year-old or 45-year-old only because the patient wants that valve for a lifestyle consideration, doesn't want to take warfarin. But then we have this discussion about, well, maybe that is okay, because if that patient needs a second operation in 10 or 15 years, perhaps that could be done percutaneously. But Dr. Abdulwahid, what do you think about that?
Well, it depends. It all depends on, I think, the new studies and long-term results of TAVI. In younger patients, how young you could allow TAVI, valve-in-valve, because how many times you could do valve-in-valve. And most of our population is young population. So yes, you could do it. Or some even recommend, I've heard surgeons recommending tissue valve in even young patients, because at least with the new valve, the long-term durability is good. And then you would avoid warfarin, and the reoperation is not, it's not difficult, let's say, and the risk is not high. So some of the surgeons recommend even tissue valve in younger age group, although in spite of the recommendations and the accelerated degeneration of the tissue valves. Yeah, maybe 55 or 60 years, put a tissue valve, and then if the patient develops future problems, then valve-in-valve. At least once a valve-in-valve. I'm not sure how many times you could put valves in.
Please stay. Well, thank you for the question. Well, first of all, they have really minimal thickness. So also obviously it's not something we try on purpose to do, but there are sporadic cases where you may have to implant 3 valves because for some reason the first valve was not in position, even the second wasn't, and the third works well. And this doesn't lead to any gradient. So it's not a matter of how many you implant. Of course, it's different when you have degenerated leaflets of an already implanted biological valve, and doing a second time might be more complex. So as a long-term, lifelong strategy is difficult to consider. One point I like to mention is very germane to a point you had. When you have a patient you can't trust in terms of follow-up, it's sometimes difficult to go to a strategy where the valve is due sometimes to fail after 10, maybe 15 years, but at that point, our experience is that when we have a degenerative valve, the time window to reintervene is very short. I mean, we have a waiting list of 3 to 4 months for TAVI, and all our problems were in valve, having catastrophic events while waiting.
So what's the answer? Is it yes or no? The reason I'm asking this question is a patient who was 53, less than 55, came to the outpatient clinic for, aortic valve replacement, and he specifically asked for a tissue valve. And when we asked him, he said, by the time I need a second valve, he knew quite well there are some studies going on. He was hoping that he will get a...
And you will find more and more patients asking that question, because it is happening.
I think patient's choice is important too.
Yes.
If the patient, even at 30 years or 20 years, let's say, chooses a tissue valve and does not want to take warfarin, for example, then you should respect patient's choice. But he needs to understand the disadvantages of putting a tissue valve in young age group.
We'll let Sir Magdi have the final word.
No, sorry, I mean, I think it's all psychological, and the idea of a redo being a dangerous operation is outmoded, because you can operate twice, 3 times, and with the same perioperative mortality of 1 to 2%. And the recovery of the patient can be very, very quick. So the idea of reoperation is a disaster, has done a lot of harm because of late referral of patients who require reoperation, or indeed TAVI, but you do have the option of reoperation at the second or third or even fourth, performed fourth. So we shouldn't be against that.